So hello everyone, my name is Thillini and I have my colleague Conor here. We are third-year medical students and today we are going to be discussing our recent systematic review on the topic of hand hygiene and healthcare-associated infections. So healthcare-associated infections can be defined as infections that arise following the use of a healthcare service. So in Europe alone, 3.2 million people are affected annually in acute care hospitals, and this contributes to about 37,000 deaths, 25 million extra days of hospital stay, and an economic burden of 13 to 24 billion per year. It is now well established that the most effective way to prevent healthcare-associated infections is to practice hand hygiene. However, low rates of compliance amongst healthcare workers have been reported globally. And now, in the context of the COVID-19 pandemic, the importance of healthcare worker hand hygiene compliance has been brought into focus. And so we aim to provide an up-to-date systematic review of clinical trials assessing hand hygiene interventions in order to inform healthcare leaders and practitioners the best approaches for reduction of healthcare-associated infections using hand hygiene. So we searched 6 databases for clinical trials published between March 2014 and December 2020 on the topic of hand hygiene compliance amongst healthcare professionals. From these searches, a total of 332 papers were identified, of which 57 met the following criteria. So they were clinical trials conducted in a healthcare setting, involving healthcare workers, reported compliance with hand hygiene measured either by observation or electronic counters, provided results of hand hygiene compliance rates, and were published in the English language. Okay, so of the 57 studies included, it was found that the majority were performed in Europe, Asia, and North America. Further analysis showed that 61% were conducted in high-income countries, and only 4% were performed in lower-income countries. In terms of the clinical setting, the most studied clinical setting was the medical and surgical wards. Dispensaries were the second most common, and the adult ICU was the third most frequently assessed clinical setting. Nurses were the largest group of healthcare workers studied, followed by physicians. Okay, so hand hygiene opportunities can be defined as a point in time when any one or more of the 5 moments of hand hygiene outlined by the WHO is present and observed, either directly or electronically. So this can include before touching a patient, before aseptic procedures, after body fluid exposure or risk, after touching a patient, and after touching the patient's surroundings. Collectively, the studies reported 318,819 hand hygiene opportunities from direct observation and over 34.8 million from electronic counting. So the majority of the studies assessed multimodal approaches, although 30% utilized a single intervention. And of the interventions described, education and training was the most common, followed by performance feedback and hand hygiene reminders, whereas improving teamwork seemed to be a focus in relatively few studies. There was wide variance in baseline compliance ranging from 2 to 88%. However, the mean compliance before intervention was 41%, and the mean hand hygiene compliance after intervention was 67%. And therefore, the mean net effect on hand hygiene compliance was an improvement by 26%.
Okay, thanks a million, Thillini. I'm just going to take over from here and start off by saying that hand hygiene is global. So this is something which anyone can take part in. Our particular focus was on healthcare workers, but this isn't limited to any country. It's not limited to any system or any culture. And the reason for that is because it's cheap, it's effective, the knowledge about it is easy to transmit. However, the clinical research so far has been focused in intensive care settings. So mainly, as Thillini mentioned, the ICU, the surgical and the medical wards. And one representation of this is a perfect flip here. So primary care in the United States accounts for about 55% of all patient interaction. And yet, in our studies, only 5% of the studies actually involve primary care at all. So there's a huge disparity in terms of what's actually going on the ground and then the research that's going on, in the literature. A second paradox here is that the geographic concentration of the clinical research tends to be in wealthier Western countries. Now, if you look on your screen here, you'll see a map, and in dark blue, these are the high-income countries according to the World Bank classification. These have traditionally tended to be where hand hygiene research tends to be focused, And more recently, there's been some clinical interest in Asia, in particularly China. But in general, most of the research is corresponding almost exactly to the map of wealthier and Western countries. So that limits how our hand hygiene research data can be applied. However, there is some promising research coming from African countries, from South American countries, and in general, the research is starting to become more internationalized. So our findings really encourage exploring the reasons why those are the patterns, despite it being cheap and effective, exploring more research in what we would call non-traditional settings, so low-income countries, African countries, South American countries, and in particular primary care settings, looking at international research focused across geographic and political boundaries, and as well as that, investment in these non-traditional areas. So then we can look at how this non-traditional research might take place. There are multinational organizations here which have quite a sway in the world of hand hygiene research, and the biggest of which is the WHO. So 38 of our 57 studies, that's 2/3, were actually involving a direct design, influence, and materials and research from a large multinational organization. In the case of 37 of those, it was the WHO, and the INICC, which is another organization, were involved in a few more. So these organizations are involved in gathering data. They're involved in producing research and guidelines. They're involved in producing and distributing information and materials, such as this poster on the 5 moments for hand hygiene, which can be used directly in any healthcare setting. They're involved in coordinating and carrying out interventions. And perhaps when we speak about coordinating international cross-boundary research in non-traditional areas, that these multinational organizations, which are already set up in these areas, they might actually be the solution to the problem. One question I think that naturally comes up from a study on hand hygiene interventions is, which is the best? And that's what everyone wants to know. That's the real bang for the buck. But we don't really have the answer. And the reason for that is because there's been heterogeneity of research so far. What that means to us is that the research has been carried out in different settings. It's been carried out using different measurements, different length of studies, different techniques and interventions, and different observation methods. So what we do know is that researchers tend to favor multimodal interventions, and that may be a cause of bigger organizations like the WHO and the INICC, whose packages involve about 4 to 5 or multimodal interventions. Only 30% of our studies use a single intervention. We can't at this point say that using single versus a more complex intervention is beneficial to any institution. However, so that's saying our data doesn't support that. We think that there could be an area for more standardized research, which might give us the answer to the question at the top of the slide here. So we're looking for more homogeneity or standardization in terms of time, follow-up, method of observation, type of setting used, type of healthcare worker involved, and maybe specific research to setting type. So I mentioned bang for the buck, and I've quite cheesily changed the E's to the euro signs up here. We talked about a 26% net improvement. So I'm just going to give you a bit of context for what that might mean for, let's say, the Irish healthcare system. So there was an American study which showed that a 1% improvement in hand hygiene in staff in a 200-bed hospital was a $40,000 saving. Now, we've gone back through the OECD records and found that Ireland has over 14,000 hospital beds. So if 1% improvement in a 200-bed hospital can get you $40,000, we might consider what 26% improvement might mean in 14,000 hospital beds. We can redirect resources that we're saving from reduced healthcare-associated infections into the public health infrastructure. That means reducing waiting lists. That means reducing the time people are spending in hospital. That means reducing the amount of medication people are on. And in general, it means people are less sick, they spend less time in hospital, and they live longer. And I suppose to visualize that, it really means turning this into this. So to finish up, a few take-home points. One is that hand hygiene works. It reduces patient morbidity, the amount they're sick. It reduces the amount of time people die, and it reduces the costs of healthcare. The interventions work, so 98% of our studies achieved a positive outcome. The interventions save money that could be spent elsewhere in the health system. There are support networks, designs, and research available, and more clinical research, as always, is needed, in particular primary care settings, rural settings, low-resource environments, and African and South American countries. In particular, we'd like to say a big thank you to you for your attention and to Professor Colm Dunn for his support, guidance, and input on the study. Thanks a million.
Well done. Thank you, Thillini and Conor. especially given the complexity of a joint presentation through an online medium. So thank you for a very interesting presentation and for keeping within the time allocated.